Hello, I'm Dr. Susie Cooper and I am going to be examining Mike for his lumbar spine today. So, hello Mike, how are you today?
Morning.
Good. So I'm going to have a look at Mike's back today. Obviously the way that one examines for the lumbar spine depends on the history that you've taken. Clearly that will slightly change the way that you do your examination. For example, if someone is you're concerned about an occult cancer or metastatic disease, you obviously change your examination slightly, but the essence is still the same. It's important to look at the age of the patient. If one is looking at a younger patient, you're more likely to be thinking about mechanical spinal disease or even inflammatory spinal disease. So a patient who's young, a young male who comes in with early morning stiffness and symptoms suggestive of ankylosing spondylitis, but a very different type of findings to somebody who's got nerve root compression typical of a lumbar spine disc prolapse. And in the same way, an older person, there's always that risk that if there are concerns in the history, that you could be looking for a tumour in the spine. So it's always important to tailor the examination to that. But Mike, I know as well, he's got no back pain, have you, at the moment? So first thing I do with a patient with back pain is I look at them standing up. Ideally you expose as much of the spine as you can, which Mike is kindly done here. And I'm looking at the spine. I'm looking for, is it nice and straight? Is there any evidence of a scoliosis, which will be exaggerated when we flex him over? I'm looking, has he got symmetry? Symmetry of the legs. What are his gluteal muscles? Is there a decent gluteal muscle bulk, which he seems to have here? I also am looking sideways on. Thank you, just on sideways. I'm looking at the abdominal musculature. Is it lax? I'm looking at the cervical, the normal curvature of the spine. So the degree, just head up, cervical lordosis, the normal thoracic kyphosis, and the lumbar lordosis. These look normal. So I'm now going to turn Mike round. I'm going to look at the posterior superior iliac spine here, indicated by the skin dimples. And I'm going to ask him to flex forward, bend forward, keeping your knees straight, as if you're going to try and touch your toes. I'm looking for the whole of the spine, looking for any scoliosis, which will be exaggerated as you do that. Then you'd like to come back again for me, Mike. He's got a little bit of a flat back, but quite reasonable. And then a little bit more than I'd like, but that's fine. We can work on that. And then arch backwards. I'm looking at extension, which is fine. And then laterally, run your left arm down your leg. That's it. It moves, there's fair movement there, and then down the right leg. That's good. So we're looking at lateral flexion there. Then I'm asking him to put his arms across his chest and rotate his upper body round to the right and to the left. Really, that's more of a concern in younger people with inflammatory spondyloarthropathies, and I would, at that point, measure chest expansion, but that's not what we're needing to do here. I then like to do the shoulders index. So we measure 10 centimetres from the posterior superior spine marker, and I ask him to, again, keep your knees fairly straight and bend over as if to touch your toes. And I'm looking to see how far that 10 centimetre marker moves. And it moves, in fact, to nearly 20 centimetres in total, which is entirely acceptable. Anything above 5 to 10 is good. Anything above 5 is fine, but ideally we want 10, and he goes to that. Next thing I can do for the sacroiliac joints, which might be appropriate in a younger person or someone with ankylosing spondylitis, is to ask him to stand on one leg and arch backwards. Arch backwards for me. Any pain there in this part of his spine? And then do the same on the other side. Good, and arch backwards, fine. And he's not getting any symptoms in his sacroiliac joint. I'm now going to ask Mike to walk for me. That's very important, obviously. So this is gross neurological testing. Obviously you're just getting a full, you can see that he's walking normally. And then I'm going to ask him to walk towards the door on his heels. This is testing for any foot drop at all, which of course is out for 5. And then back towards me on his toes, please. And that's testing for S1, nerve function. Excellent. I'm going to ask Mike to sit on the edge of the couch for me now. And ask him to again bend forward. I like to test for any tenderness of the spine this way. It's easier than if they're standing up. I'm just going to palpate all the way down the spine first. Is there any tenderness there at all, Mike? And then a little more firm if I am concerned about tenderness. And there's no tenderness at all. One can be more forceful, right? It's not appropriate. And then another test that's useful to do at this point is the slump test. So So if you could just slump down, Mike, that's it. Chin onto your chest as much as you can. And I ask Mike to straighten his leg. And I do the same on the other side. This is testing weight just as the straight leg raise does. That's why you can sit up now. For sciatic nerve root impingement. If there was sciatica or nerve root impingement or irritation, that would be very difficult for him to straighten the leg, and he would inhibit doing that. Right, thank you, Mike. If you'd like to lie down now, bring your head right up, and I'm now going to look at the legs now from a lumbar spine point of view and from a neurological point of view. The first thing I do is I like to always just quickly check the hips to make sure that there's a lot of hip pain can present as spinal pain, so it's quite useful just to briefly make sure that the range of movement in the hips is good. His is excellent, there's no catching or stiffness there. And then I'm going to do a straight leg raise. So I bring the leg up to 60 degrees, and then there's no pain there at all, is there? If he had nerve root impingement or compression, he wouldn't like that at all, he wouldn't allow it. So down about 15 degrees, and then dorsiflex the foot, and there's no pain, and he's not inhibiting that at all. And the same on this side, up to about 60 degrees, no pain, lower about 15, and again, dorsiflex the foot, and that's excellent. So I'm quite happy that he doesn't have any nerve root impingement, compression, and so on there. And I'm going to check for neurology here. So I'm going to ask Mike to bend his knee and to kick out against my hand. That's good. And the same on this side. Good. Kick out. That's L4. Bring your toes up towards you, please. Toes up towards you. Stop me pressing them down. L5. And then if you can point your toes down, point, and stop me pulling them back. And that's S1. And you can see that that's all fully normal. That's normal. Next thing I'm going to do is check for sensation, which I'm expecting again to be normal in this case. L4, tell me if the little pinprick I do, that it feels the same on both sides. So I'm just going to tap on that, and it's the same both sides. Good. That was L4, and L5 between the toes. Yep. Feel that's good, and S1. Feel that. So those are the dermatomes for L4, L5, and S1. The next final neurological test is, of course, the reflexes. So I start with his knee jerk. Just relax. Clench your hands together. He doesn't have particularly strong reflexes, but I think that's, and relax the knee for me, and we did on both sides. Good, good. And then the same for the ankle jerk. So that's L4. The ankle jerk, looking for movement in the muscle. L5, do the same on the other side. That's S1, and then L5 is the hamstring reflex. Again, looking for that reflex, and obviously one would repeat it on the other side. So, and one would expect to find no asymmetry there. So knee, L4, hamstring, L5, and the ankle, S1. So the next thing to do now is to ask Mike to kindly go onto his tummy, please. And I like to just, while I'm here, I check on the sacroiliac joints. Does that hurt at all, Mike, if I do that at all? There's one little tenderness. And we've already palpated his spine. You could do that then if you wanted. Now I'm going to do the femoral nerve stretch test. Bend your knee, Mike. And I'm going to ask, bring your leg up straight. Does that hurt at all? No. So this is testing L2 to L4. Straight leg raise was to L5 and S1 nerve roots. Same on this side. And then back up. And that's entirely negative, which is excellent. So, that's fine, Mike. Thank you very much indeed. So, Mike's lumbar spine examination is really very good. He was